go.
Welcome back, everybody. It's great to see you again. We're so lucky to have Julia Rowland present today, and I have to have Susie Lee help me with that because she was the one that got me into this thing and knows Julia, Dr. Rowland, very well. Susie is also a long-term Hodgkin survivor, and you've all read about her by now, but she's someone I admire and adore. So I'm going to let her do the proper introductions, and I'm going to shut up for a change, and we'll talk later. Okay.
Thanks, Erin. I'm going to do a very, very brief introduction because Julia's got so much to share with us today. But I just wanted to let you know that I met Julia very, very early on in the mid 80s when shortly after we founded NCCS. And to me, Julia has been one of the most important people in the survivorship movement to really move survivorship forward in an academic sense, so that all of our professionals can really take advantage of learning about survivorship and making it a real part of the survivorship care and continuum. So I'm going to let Julie introduce herself again, and she has her bio up on the website. So you can read all of the stuff that she's done over the years, which is just absolutely amazing. And one thing that I would like to say is all of us who are Hodgkin survivors joined this club reluctantly. It was thrown upon us. There are professionals like Julia who actually took it upon themselves to join and really help those of us who are struggling so throughout all of this. And I just really, really appreciate anyone who has come into this to give their expertise and help. So with that, I'm going to introduce Julia Rowland, and it's all yours, Julia.
Oh, Susie, thank you for that really lovely introduction. It is such a pleasure to be with you today, this really wonderful group that's emerged, a very important and necessary group for you members who never chose to be members. I think that that's a true statement, Susie, and thanks to Erin and Susie for the invitation to be here and to, if you like, sort of share what wisdom I can with this group, recognizing that everything I tell you today has been learned from survivors themselves. So, you know, the wisdom that I share comes from thousands of individuals who've been living with, through, and beyond, as Susie famously has said, a diagnosis of cancer. My specific topic this afternoon, where I am at least, maybe morning still for some of you, is about the resilient cancer survivor. It's what happens after treatment ends, because so many survivors have told us it's not over when it's over. And in particular, I will focus on the psychological aspects because that's what I'm trained in. I'm trained as a psycho-oncologist, and I will tell you a little bit more about that field in a second. And I view the slides that I brought today really as a starting point for a dialogue and a way to frame our conversation. So I'm hoping that it will give you lots of ideas to consider and a place for us to jump off of, if you like, going forward. So I am going to hide my video because I find it very distracting to see myself in the corner of my slide. That's very weird. And somebody's going to kindly remind me when I finish my slides to put myself back on video. So thank you in advance for that. So I thought what would be really important for this community is to make sure we're sharing a common lexicon, that we are all using the same language to talk about different things. When I say cancer survivor or cancer survivorship, what do I mean by whole person care? And as I mentioned before, what is psycho-oncology? I'm also going to talk about some facts about adaptation to cancer, again, from the wisdom of thousands of survivors. And along the way, I'll share some what I think of as key take-home messages. So that's by way of introduction to what we're going to cover. So the first of these are definitional issues. So who is a cancer survivor? And I embrace, along with your National Cancer Institute, The definition that was promulgated or put forward by the National Coalition for Cancer Survivorship back in 1986. Back in 1986, of course, we didn't use that term survivor very much. And when we did, it was referring specifically to an individual who was still alive 5 years after a diagnosis with no apparent evidence of disease. At that time, 1986, more than 50% of people diagnosed could expect to be alive in 5 years. And this very thoughtful, committed group of 24 individuals, including Susie, said, we can't use that language. It doesn't benefit us. We can't wait, put our lives on hold for 5 years before we start resuming full court living here. And so we're going to think about what it means to be a survivor in a different way. And they promulgated this definition that philosophically anyone who's been diagnosed with cancer is a survivor. And importantly, from the time of diagnosis to the end of life, no matter what that person dies of, whether it's cancer or cancer related or totally not relevant. In their wisdom, they included caregivers and family members as survivors. That's like a whole topic for another conversation if we want to have that at some point. But I want, because this has been, in many ways, it was a wonderful thing to do. It was also deeply controversial, as you might imagine. I could guess if we went around the room today, talked to every one of you and said, what do you think of that term survivor? There will probably be people in the room who said, I never use that term. I never think of myself as a survivor. I don't like the label. Well, I want to hasten to say, and I'm sure Susie would leap in and say likewise, that the coalition never meant it to be a label. What they wanted to do with it was three things. One, they wanted to get rid of the language of victim. And I would have to say they've been very successful with that, because if you look at the media, if you look at on the air, everywhere, we don't see that term anymore. And people, actually die of cancer. And, if anything, they're courageous about it or face it with fortitude, but the word victim is gone. So I wanted to get rid of the word victim. The second is they wanted to convey a message of hope, that there was, in fact, life worth living after cancer, that it could be full and rich and meaningful. Most importantly, what they wanted to do with that definition is spark a conversation. They wanted to change the philosophy of care, that you had to think of a person as going to be a survivor from the moment of diagnosis, because that was the only way you were really going to design and deliver care that met the needs, preferences, and wishes of the individual who is going to be treated. If it's about fertility preservation or limb sparing or different kinds of approaches to care or how it's going to be delivered, by whom and where, those are conversations that need to occur before treatment starts. So a very powerful part of that movement, of the National Coalition's movement, was changing the definition of what it meant to be a survivor. Whether you call yourself a survivor or not doesn't matter. A lot of people call themselves thrivers, or just someone who has a history of this, or don't talk to me about it at all. I don't want that label, but it was never meant as a label. The second term I want to talk about is survivorship. So what do we mean when we talk about cancer survivorship? And there are actually two parts to this term. The first of these really relates to the care. So this is a diagram out of the IOM report on cancer patient lost in transition documentation from cancer patient to cancer survivor lost in transition, a report that came out in 2006, I want to say 5. And they defined as the survivorship care component anybody who was sort of in this box, if you will, the yellow box. They were either cancer-free or they are managing cancer as a chronic illness, but they're post-acute treatment, the sort of curative part in here. It could include people who still have active disease, who are on some kind of a management here. What it leaves out are people who are in the very active part of care and the people who are months away from death in some way. And I don't know, it looks like it's clipped off on my screen, but if somebody has a recurrence, they loop back around and start this whole circle all over again. So this sort of care includes all these people. People may be living with no disease at all, with some level of disease, but doing well out there. And there are more and more of these individuals. In the United States alone, there are over 17 million individuals with a cancer history. we can't tell you because the data is not captured for this is where they really are in their trajectory. We can surmise it from time of diagnosis. So if somebody's was diagnosed 20 years ago, we can assume they're a long-term survivor. But if they're in their first year, we can imagine that they are in active treatment. And we can also imagine people who are a year from death, and there are mathematical models. You can estimate that. But let's be generous and say there are 2 million in around early diagnosis, and there are 2 million who may be 6 months out from death. That leaves the bulk of people in the survivorship care trajectory. And I think that's really important because we think of this as kind of a limited area. It's actually most of survivors are in the survivorship area. And then the idea is, what do we mean by survivorship research? And the reason that this, of course, is appealing to me is because I had the privilege for 18 years of directing your Office of Cancer Survivorship at the National Cancer Institute. Founded in 1996, in part by incredibly compelling lobbying from the National Coalition for Cancer Survivorship and the wisdom of then director Richard Klausner at the Cancer Institute. He created the Office of Cancer Survivorship that I had the, as I said, the honor of leading. And this very long-winded description tells you about the science of that, because for so long, up until 96, the Cancer Institute, of course, known for its funding of primary cancer research, fundamental research into the mechanisms and causes and treatment of cancer, but not a lot about what happens when you're successful. And to me, the biggest measure of success that we've had in cancer is the growing number of survivors. That is a huge testament to our ability to treat earlier, detect earlier, have more successful outcomes, support those individuals. But what the coalition realized, and we realized, is we don't have the science about what happens to people when they're 5, 10, 15, 20 years out. So this is the office that supports that science across the entire institute. I'm pleased to say it's grown over the years, and we've got lots of data on what happens to people and how can we prevent or mitigate some of the adverse outcomes. The third thing I want to talk about is whole person care. So what do I mean about whole person care? And I love this definition by the World Health Organization as the state of health encompassing complete physical, mental, and social well-being, not merely the absence of disease. I think that fundamentally is very important for us because we continue in this country to be very medically modeled in our care, that we focus very much on the body, care is directed to a body. And somehow we forget that body is attached to, that your mind, and that they are integral pieces, and that you need to be taking care of the whole person. So their mental and social and economic well-being and existential, along with the physical. And towards this, I think it's also important to know that health-related quality of life is defined by the government under healthypeople.gov, also encompasses all of these. It's multidimensional, looking at physical and mental, emotional, social, etc. And that it's all of those have an impact on your quality of life. What we've seen happen, which again is fascinating to me over the past, I would say 15 years, is a shift from a focus on cancer treatment as not simply improving lifespan, but designed to optimize health span. Health span is kind of a cute new term for, the quality of your life across that life that remains to you. And it makes it a very different kind of a approach to care when we're looking at your health span, not just how long we can keep you here, because I know in this country, we have plenty of treatments that can keep you here beyond any reasonable desire to be here. And I think that that is really important that we focus on health span. And we also know in cancer that language is important, just as changing the definition of survivor is important. In this arena, I'm going to share with you one of my pet peeves. Still in the medical community, I hear my colleagues talk about patients who fail treatment. I'm sorry, I don't know a patient in this country who has failed treatment. Treatments fail all the time. Patients cannot fail treatment. So anytime you hear a physician talk to you about it or hear them mentioning this about someone else, I hope you'll step up and correct them, as I take the liberty of doing all the time. And it does bring people up short because they realize the truth in that. Our treatments fail. Patients cannot fail treatments. But I wanted also to talk about these terms, alternative and complementary care, because they were kind of hot topics for a while. As many of you may recall, Back in 1991, the National Institutes of Health created what was known as the Office of Alternative Medicine, when things like Laetrile in the cancer world, it's a apricot pit derivative, were hot topics, and the NIH, Institutes of Health, wanted to know, well, did they have any efficacy whatsoever? So they created this Office of Alternative Medicine. The presumption being that you're doing this instead of receiving conventional care. Well, they realized not too long after that, maybe longer than they should have, 1998, and changed the title of this entity to be the National Center for Complementary and Alternative Medicine, or NCAM, as many of us referred to it for many years, which acknowledged that you might be seeking complementary approaches to care, yoga, meditation, special dietary practices, creative opportunities, etc., as part of your care package, if you will. Now, as of 2015, we refer to this as the National Center for Complementary and Integrative Health. We've lost that term alternative altogether because we realize people seek a variety of ways to address their wellness and health, and that most of these focus on helping individuals receive not just care for their physical well-being, but for their emotional state, mental, social, spiritual, etc. So language is important, and it's shifted over time, and it makes us look differently at what we're delivering. And I love in the comments here, someone's put in soul care. Absolutely, that is part of health and well-being. So the final definitional thing I want to talk about just briefly, though, is what is psycho-oncology? And here again, I was very privileged back in my graduate student days to run, my path ran across that of the woman who would later be referred to as really the grandmother of the field of psycho-oncology, or the psychosocial aspects and behavioral and ethical aspects of cancer. And that was Dr. Jimmy Holland, who went on then to establish the first psychiatry service in 1977 at Memorial Sloan Kettering, a psychiatry service in a cancer hospital, unheard of before that. It is now a department. She is sadly no longer with us, but she helped really pioneer the field of psycho-oncology. I got to be, her sidekick, and we co-edited the first handbook of this along the way. Since then, there have been about 4 other editions of that. But there are 2 parts to this. It's the psychological responses to patients at all stages of disease and their families and caretakers, but also the factors that may influence disease process. So it's the 2 sides of it. What does cancer do to the person, and what does the person bring to this experience that might alter outcomes, risk and outcomes? And I would argue that really helping individuals heal within and beyond the body is the key challenge for psycho-oncology care, as since its founding and to this day. All right, you all with me? Any big questions come up that I haven't answered? All right, so I want to run again briefly through what I feel are some of the key lessons that we've learned in here. And there's no question, but we can give general statistics. When you go in and you ask your healthcare providers, what can I expect with this? They're going to give you a range in here and a big estimate. But the truth is, each person's cancer journey and their experience is indeed unique, and it's driven really by 3 big components, if you would, what they bring to it personally. For example, their prior history of trauma or of illness, of wellness care, of their coping, what their life situation is, where they are. I'm a developmental psychologist as well as a clinical psychologist by training. And so I'm always fascinated by when in the course of an individual's life they develop cancer, because clearly cancer to 3-year-old versus a 30-year-old versus a 70-year-old is very different, because we have very different challenges in the context of what's happening to us. And certainly one of the things that's challenging about Hodgkin's disease is it happens frequently in younger individuals, young adults, right in the middle of you're taking off your life, you're getting your interpersonal relationships together, you're maybe starting in the workforce, and it's just, the timing is horrible and creates specific challenges. And the flip side of that, because it's a cancer that tends to occur in younger people, you have a big lifespan ahead of you. Well, it's not like having cancer at 70, where maybe you have 20 years of risk going forward. You may have 40, 50 years of risk going forward. And how do you cope with that? Other things that contribute to adaptation in here is the medical circumstances. Are there medical treatments available? Where you're getting your medical care? What kind of rehabilitative options are offered to you? Whether you had that important conversation about what was important to you when you decided on your care, which many people come back later and say, I just went in, they told me what to do, I did it, I didn't even think about what the late consequences might be because nobody talked to me about what these risk factors might be and whether I could have mitigated those earlier, prevented them from occurring. And then finally is the whole social context within which cancer occurs, what kind of support you get from family and friends, et cetera, what your resources are, what kind of cultural influences are occurring, or cultural biases, if you like, or social stigma, which fortunately across this country at least has diminished remarkably over time. We talk about cancer, it's in the news, it's in the press. That didn't used to be the case. It was the big C or wasn't talked about at all, some lingering illness. The good news is cancer's out of the closet for most people. And that's really important because then we can talk about its impact and we can deal with its impact. What I do know too, though, from the research and work that I've done, that there are these 5 factors that are really important in mitigating or changing and achieving better health, quality of life, and improved survival outcome. First and foremost, of course, is accessing state-of-the-art care. This isn't always possible for some people, depending on where you live and what resources are available. But we know from the literature that people who go to high volume, high quality centers do better, in part because they have more resources, state-of-the-art care offered to them. Doesn't mean you won't get really good care in a community setting, just means that accessing this and being knowledgeable about it, being an informed consumer is really important. And that informed consumer is part of this other factor that's influences outcome. That's being an active participant in one's care and one's health behaviors around that. We're going to come back to that because everybody has a role to play when treatment ends. But active participant doesn't mean you necessarily have to make all the decisions. You can delegate those, but you're actively delegating. And you may ask a family member to say, what kind of care or research this for you, or you might invest your healthcare provider in that, given that he or she understands what's important to you. So being active, and because what we do know is people who are passive in the face of a cancer diagnosis struggle more because they don't get the information they need, they don't get the help they need, and they may give up prematurely, which I hate to think happens anymore at all. The third in here is using a support network is important, having it and using it. What's interesting to me here as a research scientist is just knowing you have people available to you is often sufficient for people. In other words, I know there's someone I could call if I need to drive right away to the hospital. I know I could search someone I can call who would, if I'm feeling blue, I could just tell them everything and let my hair down and weep, uncontrollably, and they could deal with that. But there are really 2 parts to this. It's having it, but using it when needed. And a lot of us are reluctant to do that. I will remind this smart audience that it's a gift to those who care about you to let them care about you. So when you're feeling reluctant to ask friends for help or support, remember that you do them a favor by allowing them to do for you something that'll make a difference. So it's ultimately a win-win situation. The data on social support, and again, I'll come back to this at the end, is very compelling. Social support mitigates all kinds of health outcomes. So to the extent that we feel supported and is important, it's why COVID has taken such a hit on the community at large. The isolation is not good for us. And of course, we said socially distanced instead of physically distanced. If we'd said physically distanced, but socially lean in, that message may have been important for us, because really that's what you want when you're in a crisis. You want community. You want the resources available. Last 2 in here is finding a sense of meaning or purpose is important because it helps one commit to arduous care, difficult follow-up, living with this. You have a reason to be here. I think cancer, one of the things that cancer does for us, as a lot of major life events do, it makes us take a step back and take stock and say, why am I here? What am I doing? What does this mean? How do I make sense? How do I move this forward? And having a sense about that. And it may shift over time. Your reason for being here may be different. I realize it's different for me as a retired person, that I have to reframe my life. And part of it is I have grandchildren, and I realize what a big part of my life they are, but it's a shift. That wasn't what it was like during my career. The final in here, and I keep telling you I'm going to come back to this, I'm going to come back to this, but learn to express oneself. Because I'm going to, little teaser here, I'm going to talk a little bit about the organization I work for now, Smith Center for Healing in the Arts, where we're all about finding creativity in the life that you lead and finding a way to express yourself, whether it's on paper, in dance, in music, in voice, it's whatever it is, it's learning to be in touch with yourself and allow yourself to be fully present and share that with other people. So learning to express yourself. Nothing new to this crowd either, that cancer affects virtually every aspect of an individual's life and function. I think people don't think about this a lot at the time, and this slide really just lists some of the things here, but what I really want to emphasize in this is how many of these are in the psychosocial domain. Yes, there are plenty of physical things that people who have a cancer history deal with: the pain, the memory problems, sexual impairment, second cancers, cardiac problems, bone health issues, functional decline. And this last one up here in the physical medical, which is kind of the hot new baby topic, is the idea of premature aging. And certainly our Hodgkin's disease survivors diagnosed younger, if they're under 50, and have fairly aggressive treatments. What we're seeing, as we saw in our childhood survivors, where we've made the most progress in childhood cancer, is this whole idea of premature aging, that maybe our treatments and the cancer cause people to look older than their peers who don't have this history. And it's kind of an intriguing, I'm happy to talk about it later. It's really an intriguing area because, of course, cancer is the disease of aging. So to begin with, our risk factor sadly goes up for this. And in fact, again, Hodgkin's disease survivors are very acutely aware of this because you're now living long enough to, oh, look, have second and third malignancies. Oh, joy, oh, bliss, the gift that keeps on giving, your treatment. Anyway, I think this idea of what's accelerating that process and what puts people at risk is a big scientific question that we're going to see much more research on. But you look at all these domains in red, and that's the psychosocial component in here that often gets short shrift when we're dealing with individuals who have a cancer history. And we know this makes a difference. So does this light up in yours that it's showing the circle on here? Yeah. This is data on health-related quality of life among individuals. It's a little bit dated now, but the National Health Interview Survey is a national in-person, on phone actually, survey of non-institutionalized, population-based representative sample that's conducted every year. And we get to aggregate this data, and we can look at those who have a cancer history and those who don't. And as you can see here, our cancer survivor population all across the board, whether it's physical health or mental health or the two combined, have much larger, twice as large proportions of individuals who report poor physical health, poor mental health, or the two combined. Again, very sobering data. And you ask, well, what can we be doing to change that pattern? And part of that is we need to address the psychosocial needs of individuals. So we're really giving this a place in the standard delivery of care, quality care. This is another Institute of Medicine report, Cancer Care for the Whole Patient, released in 2006, I want to say. And basically what this report said was, we're doing a great job on the medical side. More and more people, earlier diagnosis, better treatments, better supportive care, et cetera. But you know what? We're really falling down on the psychosocial piece of this. And three take-home points from the larger report is that majority of people who are diagnosed and treated for cancer cope well. They are resilient. And this talk is about resilience. And if there's anything to me that's striking about the work experience that I've had for the past 40 years, it's my deep respect for how resilient people are, how much we can throw at individuals and they keep coming back, kind of like the old image to me, and it's going to date me. I think, you remember those bozo clowns that you had the sandbag at the bottom and you punch the bozo went back and the bozo stood up again. I think I sometimes feel it's like that. You just keep, batting people down and they keep coming back and being resilient in the face of this. So the vast majority of people are incredibly resilient. Doesn't mean that they don't need any support. They clearly need some. But the other side of this report is somewhere between a fifth and a third of individuals need more intentional outreach if they're going to cope well and do well. And this is the population of concern. And what we also know at the same time is that a variety of psychosocial and behavioral interventions work. They often work better than some of our cancer treatments. They're more reliable, they're more robust, and they're a lot less expensive than some of the medical care that's being delivered. So we have several meta-analyses cited here where we've shown that these work. The question is, how do we identify the people who need these and deliver this care? One of the national movements that occurred within, again, the last 15, 20 years is across the United States is what's called a distress screening movement, in which more and more institutions, particularly cancer centers, are being asked to screen individuals upon early diagnosis at the time of early diagnosis for what they refer to as distress, and then triaging those individuals to care as needed. A couple problems with this is, first of all, it's not the universal uptake. Second, while promulgated by my beloved mentor, Dr. Jimmy Holland, the idea of measuring distress is not actually helpful clinically, because what you really want to know is, are they anxious or depressed? Because we have treatments for that. We don't really have treatments for quote unquote distress unless we know the source of that, which may be that they're anxious or depressed, or there's social things going at home that we could mitigate. So there's that. And then the third is, we didn't set this up in a way, the programs aren't set up in a way for follow-up. So this report, the Cancer Care for the Whole Patient report, said there were really 4 parts to this. First, you had to screen individuals. Then you had to assess if they were at risk in some way. Just look at their scores and whatever tool you're using to screen. Third, if they made your cutoff, so you said they were, in need of more help, that you actually connected them with whatever that source of help is, whether it's counseling or medications or financial assistance, whatever it was, to help address the crisis that was occurring for them. But the fourth part in here that they delineated in their care was follow-up. So if you're a clinician and you screen someone for depression and they trigger your measure for the cutoff measure saying this person needs assistance, and you refer them to a psychologist, psychiatrist, social worker, and or prescribe an anxiolytic or an antidepressant medication, whatever, your job is not done. Because what you need to know is, did that work? So if you don't do the follow-up and ask your patient when next time they come back, or have a time set for following up in here, you're actually not going to know the outcome. You don't know if you wrote a prescription for a medication, whether they actually went to the pharmacy and took that, or whether they heard your message as, I have cancer, and now you're telling me I'm crazy. Heck with you. Or their family said, you're doing fine, you don't need any of that. Or they took it and had a terrible reaction to it and stopped taking it. Or, you need to know, did they actually get the care that you prescribed for them? And what was the effect? Because if they didn't take it, it's not going to do any good. But also, if they took it and didn't do any good, that's also a problem. But you also want to know if they took it and it was beneficial, because that's also how the learning system works. So if you find, I give you an example. I have a patient I saw at Georgetown when I was part of their psycho-oncology program, who became very depressed in the course of her breast cancer treatment. And very lovely woman, Latina background, culturally very uncomfortable with the notion that she couldn't manage this on her own. Her very caring oncologist finally convinced her to talk to me, and I really gave her a lot of latitude. I said, this is not about you not functioning. This is about your cancer treatment dysregulating, making it not possible for you to function the way you usually do, that is induced, essentially, has caused you to have these depressive feelings. I was fortunate enough to be able to convince her to go see my colleague, who was a psychiatrist, who prescribed her an antidepressant for her depression. And she had almost an overnight positive response to that. And in addition, her oncologist noted it addressed her hot flashes. Well, that was the beginning of a whole research project on the use of this type of medication, serotonin reuptake inhibitors or SRIs, for controlling hot flashes. I mean, it's like if we don't attend to follow up with our patients to make sure they get the care they need and then find out what the impact of that is, we also shut the door on some incredible innovation. So that's just by way of illustration and what this IOM report was intended to promulgate. Questions? I'm looking at little things in here. All right. So the fourth, again, surprise, surprise, not a surprise at all, is that cancer-related anxiety is very common. The most typical kind of anxiety we look at in cancer, of course, is fear of recurrence. Fear that the cancer is going to come back, because that's top of mind for most individuals who have a history of cancer. It's almost ubiquitous. It's probably the most common side effect, if you will, of cancer and its treatment is fear of recurrence. There is a minority of people, I would say probably less than 15% of people who really say, I've never, don't worry about it, have never worried about it. Those are likely to be individuals who have very early stage disease, who are instant reassurance, you're fine, this is no big deal, don't worry about it. But the vast majority of people worry about it at some point. And yes, it does, by patient report, diminish over time. So the further you are from treatment, the more comfortable you are that you're going to be out of this zone. But it's incredibly variable. So there are people who worry a lot. There are people who worry very little, and it doesn't necessarily go away. And I've even had patients come back and say, I was fine till I got to the 5-year mark, and then my cancer fear went off the rails. It's like there was some trigger about that 5-year indicator, which is such a wacky indicator in any case, if I can use that term, because it's not really based actually on medical data. A lot of cancers, if you haven't had a recurrence in the first 2 years, changes your risk dramatically, not 5. The 5 has never really been revisited. It's almost like an analytic number that was designated and never been revisited, which I find is fascinating. What we do know is that there are definite triggers to anxiety, whether it's fear of the cancer coming back, fear of having a second cancer, having a complication of your cancer and its treatment. So it's really broader. And people don't think about the fact that finishing treatment, and actually our clinicians don't either, while a very joyous and much anticipated event for all parties concerned, it is often a time of great distress for patients and families, because there is that worry that now that treatment has stopped, unless you're on some kind of maintenance therapy where you feel like you're actively doing something, that the cancer will come back. There's concern about monitoring. Well, I've been coming every 2 weeks, or whatever the schedule was. I have a team. I know who I can call. What happens now? You're not going to see me for 3 months. What happens in the interim? What do I do with all of these symptoms? Because, by the way, your treatments have made me feel really crummy. And how long is that going to go on? I don't feel like I'm actually bouncing back. And yet my family and friends, they all want me back the way I was before this all began, which may have been months and months ago. So the social demands on quote unquote re-entry can be an enormous challenge. And family don't recognize that there is this recovery period because it's not talked about. So all good reasons to be anxious about finishing treatment, even if it's celebratory. So that ambiguous state of saying, yay, but oh dear. By the same token, post-treatment, there are other types of triggers. The common one that everybody cites is those follow-up visits and tests. And oh, by the way, waiting for test results, some of the most toxic time there is. So learning techniques to manage that are really important. And some of it may be very concrete, like when can I realistically expect to have results from this test, so that you're not waiting and panicking because there is this sense that you should have known, and why don't they have the results yet? It can't be good. Anniversary dates, time around your first diagnosis, or if you had transplant, when your transplant was, or finishing treatment, that can trigger it. Obviously, and not surprisingly, worrisome or suspicious symptoms, change in health, weight loss, fatigue, or any kind of a symptom you might have had at the time you were diagnosed, whether it was related to your cancer or not, can be a trigger. Illness in other people, in particular family members, makes us anxious about our own health and well-being, and that survivor's guilt, as someone put in the box here, the death of a fellow survivor or a prominent cancer survivor, since we are public in this nation about figures who are well known who die of their cancer, and that can be an enormous trigger and it's hard to avoid. While it's good news that we can talk about it, the bad news is there's cancer in the news all the time. Really, do I want to hear about it? How am I supposed to move on in my life and not be constantly reminded? Interestingly, people will say times of stress, and sometimes when you're very stressed and you don't really realize what's going on, you may be worried about your cancer or your health condition and not realize that it's the stressful events that are kind of triggering this in parallel. And then finally, there's the one that I call idiosyncratic triggers. They're learned responses. We are, of course, behavioral creatures, and we learn well when we get repetitive cancer treatments that are every couple of weeks or whatever. You stop those treatments, and surprise, surprise, when that due date would have come up 2 weeks later, when you would have had a treatment, you may have all the same symptoms, even though you're not going to get the chemotherapy exposures, because we learn behavior. Similarly, we pair that up. I had a patient who happened to be a hematologic cancer survivor who, I want to say she was 12 years out from treatment, came in for something related to her cancer, but she talked about the fact that she still had very acute responses to the smell of alcohol, rubbing alcohol. It made her nauseous because it just reminded her of going in for her chemotherapy treatments. And those, again, are idiosyncratic. Probably not true of a lot of people, but maybe true for you. So what do we do to manage this anxiety? What's available to us? I've got a couple slides here. They are, behavioral things you do to reduce your physical risk. Now, obviously, first and foremost, you want to take good physical care of yourself. I think what happens to a lot of cancer patients when they go through treatment is they don't realize that there is this whole other body. It's not just the Hodgkin's disease you have to be focused on, but you have other health concerns you need to address. And so keeping a link with your primary care and having a primary care physician is very important. All the usual things that people will tell you about: healthy lifestyle, exercise, diet, alcohol, et cetera, et cetera. Certainly being smart, and again, this is such an educated audience. I feel like I'm preaching to the choir, and you already know this. I'm not telling you anything new. It's talking to your doctor, nurse, or team when symptoms or questions arise. There are no stupid questions in this field. There are no stupid questions. You have something that's worrying you, better to find out than worry for days over something that may be non-consequential. Sobering too is the fact that a lot of people misunderstand their actual risk of developing either a late sequela, whether it's another cancer or recurrence, or a late effect, let's say cardiac disease, secondary to their cancer. Having accurate information about your specific personal risk is really helpful. Obviously, to the extent that they're risk reducing interventions, terrific. So if there are things for cardiovascular health that'll promote that, or screening that you need to do on a more regular basis to prevent some complication from occurring, great to know about that. And just from a behavioral point of view, being active, I kind of want to say one of the things that's so important in the field of psycho-oncology and the field of survivorship science is that survivors are their best advocates. You are your best advocate. Learning to advocate for yourself is really critical. To the extent that you want to do that for your peers, even better. But learning to advocate for yourself is important. Speaking up is important, because what we've learned, if nothing, is that listening to survivors is critical. And who listens to survivors? Well, let me tell you, everybody down in Congress will. One of the good news about Congress, regardless of who's in leadership or not, is they have a very close relationship with the National Institutes of Health. They get it about health. And when cancer survivors go down and testify before Congress, things happen. So speaking up, letting that leadership know what's important is really vital. And then, behavioral actions you can do to reduce anxiety, not just your risk. And part of that, and the big emphasis you're going to hear me keep coming back to, is emotional self-care. That you need to take care of you, that and be compassionate for yourself. I think sometimes this is easy to forget because you may feel that everybody's taking such good care of you. Now you have to turn around and take care of everybody and forget to be compassionate in your self-care. And giving yourself permission to seek professional help if that's needed. There is no stigma to this. Although I will caveat that we live in a country where there is not parity between mental and physical health. There is more constraint placed upon mental health services in terms of reimbursement and its availability. I think there's less stigma now around workplace because there are protections in place in that regard. And my experience as a clinician is that insurers, quote unquote, get it when they know that a patient who's receiving mental health services has a cancer history. Now, they may get it for the wrong reasons. They may think, oh gosh, if I had cancer, I'd be depressed too, which is actually not the case. Most people with cancer are not depressed. But if somebody says they're depressed, that I take that very seriously, and I want that addressed. And if that's true and you feel like you're struggling, you can't get away from your anxiety or worry all the time. I think it's really important to talk to somebody about that. Can you learn strategies to deal with it? Talking to survivors or families, learn some coping techniques. One of my personal favorites is all of the relaxation training that's out there. Herb Benson just recently died. He was a relaxation response, Harvard, giant, if you will, looking at that, the fight or flight response, and how do we harness that to our best use. So we are not wearing our shoulders up as earrings, if you will, that we learn to relax, that we learn to land in our body the way yoga and meditation train us to do, that we learn breathing exercises that we can use anywhere we are. Great tools. Whether you're sitting waiting for a doctor's appointment or waiting for test results or just dealing with a frustrating work situation or a colleague or a loved one or a child, learning to compose yourself is such a gift, being able to do that. And as you do here in this group, it's providing support to peers. Again, I find the power of groups to be amazing because it provides for those members who come a sense that you are not alone in this. There are, what I wrote down the number here somewhere, about 235,000 Hodgkin's disease survivors in this country alone, with 8,100 new cases every year. And that's statistics out of 2019, not even the most accurate statistics in here. You're in good company, and sharing your knowledge and wisdom makes a difference. And it's a two-way street. So you come and you may be able to help someone else when somebody may have advice and insight that may help you. Right. And then finally, there's sort of, how do we think differently about our anxiety? And one of those is recognizing that there are trigger points, that something may have occurred that you didn't even pay attention to. You happen to notice sort of haphazardly this story about a cancer patient, and you just find yourself anxious for the rest of the day. And it may take some time to make you realize, my gosh, I didn't realize how distressed I was at seeing that news. Yes, in those days that are really tough, the one day at a time approach works well, and focusing on wellness. We are a culture, again, that kind of looks at the aches and pains and doesn't step back and give us enough space to say, I'm really grateful. I'm grateful here in Washington, D.C., that it is relatively sunny out, that the weather is warmer, that my little plants are coming up, whether they should or not is questionable, but the little crocus are shooting their little heads up. Here's still the beginning of March. We have had snow in April, but I am grateful for that. And reframing your beliefs and thoughts. What does this really mean? Is this a worrisome sign or trigger in here? and thinking about, not to be Pollyannish, but some of the positives that come out of an illness experience. I think we all have lessons learned from trauma in our lives. You know, what can we come away and recognize? Some of that is just as simple as the realization that we have people who care about us, and that who want to make a difference and want to help us, which can be incredibly powerful. And finally, I want to take just my last few minutes on this to talk about attending to whole person health and the difference that that makes. Again, you know my philosophy from the beginning. I'm a mind, body, spirit oriented clinician and practitioners. You cannot separate out those pieces. They are all integral, and you need to work on them together. And when I say that, I'm mindful of this wonderful model of care that's out of a website called Beyond Conventional Cancer Therapies, or BCCT. .ngo, bcct.ngo, a wealth of well-curated information, originally constructed by Michael Lerner out of Commonweal in Bolinas, California, and along with Susie, one of the founders of the National Coalition for Cancer Survivorship, very thoughtful thinker. So well-curated information about, you know, complementary, integrative resources for care, particularly in cancer. And what they emphasize here is what we call the 7 healing practices. And what is important to know about these is there's data behind each one of these. So we know that when you eat well, you move more. And if you were to ask me to give one piece of advice to somebody who has a cancer history, I would say keep moving. And that's probably because that's advice I would give to anybody. The data on moving and physical activity is some of the most, what's the right word? Dramatic, if you like, because it's so consistent out there for all of us that we keep moving. In fact, sitting is now considered the new smoking when it comes to poor health outcomes. So burn your chairs, no, or something like that. But I think it's ironic when we buy these very fancy chairs so we can spend more time sitting. And of course, I'm very conscious of the fact that I spend a lot of time sitting in front of Zoom. Managing stress, we just talked about that, learning techniques to manage sleeping well, under examined. Sleeping well is really, really important. Creating a healing environment, and that's both a physical environment, so you're not with toxins in your environment, there's not radon, you're not you don't have asbestos, you know, taking a close look at the environment which you live, but also you might having sacred spaces in here, and a place that brings you peace when you come home, or you have special places in your home that do that. Sharing love and support, against social support, just mountains of literature on the benefits of social support to all kinds of health outcomes. And then the idea of exploring what matters now. We talked a little bit about that, the having existential meaning. What does it mean for you to be here and now? Why are you here? And giving yourself an opportunity to explore that. And these are all things that we do. Yes, my final plug, I have to close with a plug for Smith Center for Healing in the Arts, which is based in downtown DC. It's a health, arts, and education resource that's been here for over 25 years in the greater Washington area. Its founder, Barbara Smith Coleman, and Michael Lerner, of course, founder of Commonweal I mentioned earlier, created this. Barbara Smith Coleman herself was an artist, and she was very moved by experience she had with her brother, whom she took to the Bristol Clinic in London, or in England, when he developed cancer. And she was so moved by the integrative care he received. She said, well, why aren't we doing that back here? We should definitely be doing that back here. And so she established Smith Center, where our philosophy is that everyone harbors the innate capacity for healing, and that healing is always possible, even if curing is not. And we try and meet individuals where they are in their healing journey, but with a variety of different kinds of services: yoga, stress management, different kinds of support groups, healing circles. We have a very robust young adult cancer program for those under 40 and under. Arts and creativity are woven through everything we do. We have an art gallery that is part of our space. And of course, now with COVID, almost everything we do, well, pretty much everything we do is online. So it doesn't matter where you live, you have access to everything we do at Smith Center, and almost all of it, with very rare exceptions, is free of charge. So I invite you to explore that. And with that, I'm going to stop. I've talked way too long, and I encourage us to hope that let the conversation begin. And if I can get rid of the slides, I will.
Thank you
Thank
so
you.
much,
Yeah.
Julia. I don't think you talked way too long at all. It was perfect. And I just want to make sure I heard you clearly. Did you use the word free when you talked about
Yeah.
the Smith
Smith
Center?
Center, free.
Well, I asked that because there was been some comments in the chat about specifically about the cost of therapy and access to therapy for many of those who are even on this call and survivors in general. So if you could say a few words about that, that would be great.
Yeah, so Smith Center, as I said, the important part in some ways for this audience is that it's because of COVID, we've gone online. So we've converted pretty much everything we do online. Remarkably, it translates pretty well. That includes all of our arts and creativity. Our yoga is online, and it's all free of charge. All you have to do is go to our website, so smithcenter.org. Go to the calendar, find a program you like. You do have to sign up because that's the only way you'll get the Zoom link. And there's always suggested donation. We are a nonprofit. We're a 501c3, so you'll always see, an enticement to support us if you think the work that we're doing is good, but it's not a requirement. With rare exceptions, we do run a retreat program where we have a modest cost attached to that. It's now being delivered online. We used to do those in person. It's online for the moment, but we do also have scholarships.
Great. The other people may have more specific questions about finances, but I just wanted to bring up one more subject, and I'm sure Susie wants to get in here as well. One of the comments in chat, and this comes up a lot, is the issue of survivor's guilt. And for a group like us who have survived for decades, that is something that we certainly deal with. Not that survivors don't, but certainly we have had our share of losses. And I think every time we hear about one of them, it comes as a blow. I mean, it's a direct shot to the heart. And I don't think it's something we talk about enough. We have such a umbrella of psychological, emotional issues that we're dealing with just with the day-to-day, what's going to happen to me next. But to add to that, the grieving and mourning we do for our fellow survivors is almost too much to bear. It's sort of like putting your blinders on and saying, let me just get through my own stuff. And I think that's one of the toughest things as we get older, that we have to deal with the fact that we're still surviving, but many of our friends are not.
And I think, we saw it in the chat, survivor guilt is very real. And it can happen anywhere along the journey, from early on with people who didn't get benefit from treatment to lost to the complications of treatment or the late effects, which, when I think of our Hodgkin's disease survivors in particular, have been our vanguard of identifying the consequences of curative therapy. And, it's one of these good news, bad news. Good news is you're here. The bad or challenging news is you now are at risk for all of those things that used to be putative. In other words, they would talk to you about, oh, you could develop this because you had radiation, but you're not going to be around long enough, so we're not really worried about it. Well, that's not true anymore. The individuals can expect to be here long enough to develop all of those complications. And in part, you are the learning laboratory, because based on your outcomes, the treatments of the future are being modified. So people coming behind you get a lot less, and in some cases, not any radiation, because we saw, how difficult that was. Or I think of the early Hodgkin's treatments, whereas MOP ABDV, I mean, it was like, oh, wow, that's a lot of chemotherapy. And I think the oncology community is motto, taking its lead, interesting from childhood cancer, is now that we have cures, we're going to back them off. Let's see how little we can give and still get the same effect, modified. So we protect individuals from that collateral damage, if you will.
And that's something that I think we all recognize and are grateful for, that you know, those who come behind us are not going to, frankly, suffer the way we have. But I think it still leaves us, you know, it just in a very tough spot. You know, it's hard to be grateful when you're on your second or third heart surgery.
Yeah.
You know, people are angry.
Yeah. And I mean, and I don't know, I don't want to diminish that in any way. I mean, one realization, because I've been in the field for a long time, I think probably a lot of people died of cardiac complications that we didn't realize were due to their Hodgkin's disease or their cancer history of any kind, period. We now have two competing fields, which is intriguing to me. We have cardio-oncology. So you started out as a cardiologist and now you're interested in cancer. And we have oncocardiology. So you started out in oncology and now you realize your patients are really at risk for heart disease. So there are these two fields coming together and saying, oh my gosh, we really need to work in tandem because these treatments are not benign. You know, you think of the targeted treatments. I'll take the example of Herceptin in breast cancer, which we thought, oh great, it's targeted to your HER2 marker, but oh dear, it targets the heart too. Oops. You know, I think that being mindful of what's going to be down the road for individuals is very sobering, and it's an important part of that conversation.
All right, you spoke about cardio-oncologists. Are there, and I know Susie is an oncology nurse, is there, this was asked in the chat as well, are there psychiatric oncology psychiatrists, or is there folks who specialize in people just like us?
Yeah, so that's the field I entered, that my mentor helped establish, psycho-oncology. There are training programs around the country. They're federally funded, big NIH, NCI training grants for people coming along. I was one of the first two psychologists at Memorial Sloan Kettering to get that training with a fellowship from the NIH. So yes, they are out there. We have our own professional organization, the American Psychosocial Oncology Society. If you went back to my first slide, I'm a fellow of that. But all of us are trained in that field. Now, some will go on specifically to do research. So the question is, how many of those people stay in clinical practice?
Right.
And certainly there are training modules, because Memorial runs these and other big training sites for oncologists. So in other words, you can be trained in some of the psychosocial. Do I think it's enough at the moment? No, because we're not on their, the psychiatric part's not on their boards. I know Susie and I have talked about this in the past. Same thing for late effects. We have oncologists who, we did a study of attitudes about caring for, who should be caring for psychological aspects and behavioral aspects of survivors. And there's enormous tension between oncology and primary care about this. And they both thought they were doing a swell job on the emotional part. And I'm going like, that's not what patients are telling us.
Yeah.
And at the same time, some of our oncologists didn't know, what the numbers were for some of the late effects. So do we have work to do on the professional side? You bet. Absolutely.
I'd
Susie,
like to
you want to
jump
jump in there? Yeah.
Yeah, I'd like to jump in here. One of the very first remarks that were made, a couple people remarked about being tired of being resilient. And then I looked at some of the other notes I was taking, and it all goes back to this. They're tired of being resilient. For one thing, if you go try to get psychosocial care here in Tucson, you can't even find a psychologist to refer somebody to for regular care, even if it's who knows about non-oncology or oncology care. So you can't find the people to give the right kind of care. We're often seen as long-term survivors, we're seen in the community by non-oncologist specialists who have no idea what we're going through, don't feel that we really have a right to have some of the kind of care that we have, or essentially negate the kind of problems that we're having, saying, that can't have anything to do with your cancer. So, we can't find the right kind of physical follow-up. We can't find the right kind of psychological follow-up. And all of this gets to be very, very tiring. And then we're developing the problems that lands us in the hospital, like Erin was saying, how many times you're having cardiac testing or other cancers, or all the different side effects and symptoms that we're seeing. So I think the idea of being tired of being resilient is like, what does resilience really mean? Does resilience, is it supposed to be that we're always positive and moving forward? Or is resilience just kind of surviving in the situation that we're in on a day-to-day basis? So I don't know if you can speak to any of that, but.
Oh, no, those are such wise reflections, Susie. And I mean, one way is to frame this in a bigger way, and that's to say, we want for our cancer, I certainly want for our cancer population, things that we don't even offer the general population, okay? So one of the things that COVID has made very clear is the mental health of this country is fairly fragile, and we don't pay attention to it, and we aren't developing services to meet that need. So when our cancer survivors wisely turn around and say, well, I need help with this, or tell me what I can do to promote my health and well-being, preventive kinds of things, we're not set up to do that. And that's a problem. But I guess the Pollyanna in me, if you will, always says, if there's a problem, then what's the solution to that? No question, advocacy makes a difference. And we've had a lot of advances in cancer because advocates have stood up and said, we need the science here and we need the care. Do we need to change the healthcare system in the United States? Absolutely. And so having cancer in the context of a broken system doesn't help. But what can we do constructively to change that picture? I agree. So share your question about, being your advocate. It's true. It's really hard. You have to be your own advocate. I hate to tell you that. You have to be, we all do. And if we aren't going to be advocates for ourselves, the reality is nobody else can do it for us. We need to be our own best advocate. But I also realize, people like, wait, I'm going back to her comment in here, recognizing that our young survivors is, our vanguard in here, our childhood cancer survivors are the vanguard, and they, in fact, have helped us open the window, even though those are very rare cancers. Again, is childhood cancer is a very rare condition. That's where the focus has been. We kind of haven't gone to the adult arena, and we're only just realizing, oh my gosh, this is true for our adult population too. We're going to live long term with these histories. So yeah, so we need to advocate. I think groups like this can do that. You can be a voice, a credible voice, saying you can't treat in street. That's not okay.
So Julia, what sticking with the resilience part, I love what Susie just said, but in your experience, what does that resilience look like? Tell me about a resistant long-term, or resistant maybe as well, but a resilient long-term survivor. What does he or she look like in your
First of all, you're here on this call, all of you. You're just by being here, you are resilient because you are a health seeker. You are trying to figure out what can you do for your own best care. That's point one. Point two, you're not going to feel resilient every day. So I think that don't get discouraged when there are days when you just feel, I don't want to be my own advocate. I want to crawl into a corner. Why can't somebody take care of my control? Those days are going to happen. So compassionate sense of self is important in here. None of us is resilient every day, but it's the resilient survivor is someone who uses the resources available to him or her, that knows when they're over their limit, begins to recognize, I can't do this. I've got to stop and take some time for me or get help. And being in some ways strong enough to do that. I think that we put such a burden on survivors in particular about, you did this, you did a great job, keep on doing it, keep on trucking. And there are days when you just say, wow, I don't want to do this at all anymore. And part of that is a natural response to just having overwhelming demands put on you. But it's also an opportunity for you to say, you know what? I don't have to do some of this. And in that regard, cancer can be incredibly permission giving. I'm not bothering with people who I find irritating. I realize life's too short and too precious to me. Take a hike. But it's also an opportunity to say, how do I want to change my life? Taking that, using that experience as transformative, if you will. And these aren't lessons that are unique to cancer. It's the way we should all be living our lives in some ways, to the extent possible.
I think that one of the things that has helped, and Susie, you can speak about this as well, because you've been so involved in the advocacy community in particular, but one of the things I've learned being an advocate for not that long is the beauty of doing something, putting your money where your mouth is, so to speak, is very empowering. And it kind of goes up against all the things that my body can't do anymore. And that list is getting longer. But I still have a voice. It's not a great voice right now. I've got some problems, but it's a voice. So that is, for me, something that makes me feel a little bit stronger. The other thing I would point to is the people in this group, and the people who are in this group who just aren't here today. But boy, what a difference. I can just speak for myself that I have in my life, to have other people who say, me too, I get it, been there. 10 years ago, we didn't really know each other. And now we've got this family, which is really, and that's empowering too, probably more so than anything else for me. And I'd love to hear what Susie says, because she's, like I said, been at this a lot longer than most of us.
Well, I think advocacy as a step forward after we're initially diagnosed, it's a real double-edged sword. Really going into oncology nursing, a lot of people thought I was absolutely nuts, but I needed support in some way at that time, back in the mid 70s. I was so afraid of what was going to happen in my future. I wanted to be right there and have the help that I needed. But what that did was it really introduced me to the advocacy community once I got involved with NCCS. That was life-changing for me. And I have to say, groups like Hodgkin's International, since I got involved with this wonderful group, it becomes our tribe. It becomes our place where we can feel comfortable talking about anything that we need to talk about, and get the kind of support that we're not getting very often from our healthcare providers, or very often from our family. Our family and friends don't understand very often what we're going through. And especially as we're long-term survivors, I think they kind of understand less, but it is a double-edged sword. So I think we have to learn, when we're advocates, how to take care of ourselves and take care of each other. And that's where a lot of the survivor guilt comes in. How do we take care of ourselves when we're losing so many people? How do we take care of the other people in our tribe who are feeling very, very lost and grieving because of the numbers of people that we still lose? So it is a double-edged sword. And so we have good days and we have bad days. And there have certainly been times when I've just said, I've got to step back. I don't want to think about cancer today. Once I started with all the cardiac stuff, it's like it put cancer kind of over on the other side, because I had to learn about all of this cardiac stuff. And then I think some of the people in here at the chat room are talking about the physicians, the doctors and nurses who don't listen to us, who don't know what we're going through, who don't understand. And like I said to a group of residents and interns who came into my room when I was having a cardiac procedure, wondering what I wanted to do if my heart stopped during this procedure. And I said, well, if my brain is still functioning, you better keep me going, because I've got a lot to teach you guys yet. And so I think that that's all kind of my part of advocacy, is we still have got a lot to do. And even though we started all of this way back in the 80s, and some started in the 70s, there's still an incredible amount that has to be done, because people do not understand what those of us who are long-term survivors are actually having to deal with.
agree. Julian, is this sounding familiar to you? Have you hear this all the time from folks?
All the time. And I just, I don't think there are quick answers in here. Yes, it's a mixed blessing. You come to have these very personal and committed relationships to one another, but you are dealing with a high risk population, and your exposure to loss will be greater than somebody who's in just a peer group.
Mhm.
So it's one of the challenges of cancer support groups of any kind is you will lose members as part of that. Hopefully you have somebody who helps the group navigate that, finds a way to honor those losses and help people feel whole and not panicked about their own health and well-being. And I noticed Rachel put a nice question in the chat here. What do we do? Some tips for self-care. And I think the list that I had, those 7 healing practices, is a great way to start, is assessing each of those practices for yourself. Are you sleeping well? And if not, okay, let's think about that. Are you eating well? How do you balance that? Are you moving? Do you have a support network that you're engaged with? Do you have community out, etc.? And using that as a way to kind of go through what you have in your life right now that will enrich it, because I think that's where it all starts. And I'm mindful too of Gail saying, will I ever have a nice day, a day where I feel well? And I think the question is, what would that look like?
Yeah.
If you can imagine it, what would that look like? And then figure out what would it take to do that. And I don't know if behind that question is partly the issue that we kind of I touched upon, didn't really go into depth, and that's this sort of sense of fear of occurrence. I do have some feelings about that if you are someone who is constantly thinking about your cancer, we need to do something about that. Can you get some kind of magical training to make it all go away and you never think about it again? No, that's a fantasy. But can you park it somewhere? And again, if one went around the room, I'm sure you get really a range of answers in how often do you think about your cancer in a given week or even a given day. And a lot of people can come back and say, I didn't even think about it for the last couple of days, unless you have something medically going on. So what you want is to tuck it somewhere. And if you're having trouble tucking it somewhere and it's really front of mind all the time, that's worth talking to someone about and learning some strategies to deal with that.
I think that's great advice. And I think seeing the folks who are listening today and commenting on chat, but I don't want to be a naysayer, but the problem is so many of us in this particular group are being bombarded with health issues every day. It's the analogy you gave about the clown. We used to call it the bopping on the head thing. It's really hard to find time where you're not having to think about not cancer so much, but your heart, your lungs, your liver, there's those problems are accumulative. We're finding out as we go along, not lessening. And I would love to have an answer to how to park it someplace, but I don't think there's room in most of my days to ignore it. And I would say that's probably true for, well, we have someone who's going in for heart surgery or heart procedure tomorrow. And so it's really, it's kind of every day.
And so part of it is, can you, instead of trying to make it go away, which I agree is almost virtually impossible and unrealistic, it's Sisyphean, you're going to think you can do that. But, can you either reframe it in some way and give it some space and say, I'm going to think about this for the next 20 minutes and really focus on it and honor it, and honor that this is a concern for me, and recognize it, not pretend it's not there, and then allow you to take back that other portion of your life. I made the comment earlier that what we're seeing in our long-term cancer survivors, mostly young, because our older adults already come in with so many comorbid conditions, but really much more acutely visible in those treated as young adults and children, is that idea of premature aging. So what, as a developmental psychologist, what intrigues me is, what are the lessons learned from people who are aging, with or without cancer, older folks, about how they cope with the serial loss? because in some ways, Erin, what you're talking about here is you're just accelerating the time within which you have to look at this. A, and B, you have a more concrete in some ways sense of where these problems and disabilities are coming from, these limitations are coming from. Whereas aging, they kind of blindside you from all quarters, right? But it's an aging issue as well.
Yeah.
That
I
so
think
I guess I'm trying to come up, Erin, with ideas about where might the lessons learned be? What literature could we look at to say, gosh, well, how do people who are in their 80s and 90s cope? Because they're sequentially losing function.
Well, I think what's great about today and having you here in particular is that I'm sure you kind of hear this between the lines. We want to be able to say, this is difficult, this is hard, I'm barely making it. And sometimes the answer is just to be heard, to have someone who is as smart and experienced as you say, I hear you, I hear you. And I think that's something that many of us don't always get, whether it's from our therapist or our oncologist or our, priest, whatever. I think it's just that need to be heard and have someone say, I hear you, I can't fix it, I give you some ideas, but mostly I hear you. And then especially, as I say, coming from someone who's heard it all, and you have heard it all.
And we need to hear it again and again and again, Erin. I mean, I think there are two parts to being heard. Part is the opportunity, the healing opportunity in its own of being heard. I mean, and telling your story. I mean, I think when survivors go down to Congress and tell their story, it's incredibly powerful and very moving. And I think we need all of us to tell our story periodically, to be validated, to be recognized for who we are. Don't stop telling your story. We and on the professional side, I mean, did I put that slide in there? It was an earlier version about one of the most important lessons learned. We need to listen to survivors. We absolutely have to listen. And that's critical. And then act on what we've heard and say, this isn't okay. This is unwarranted suffering. One of the Healthy People 2023, so these are aspirational goals for the country, for the state of various things. They have cancer goals in there, including, what proportion of people would be 5-year survivors by 2023. And that number keeps creeping up very incrementally. It feels like we backslid a little in there. But they put one out there that was aspirational, saying they want to improve the physical and mental well-being so that those data I showed you about the National Health Survey would make the populations look closer. But we don't have any way of monitoring that. I mean, how are we going to get to that if we're not evaluating it? So part of me, my research hat on, is saying we need to be capturing this information regularly. And how do we do that? And it's following our survivors, not just the way the SEER or the tumor registry does, whether you're dead or alive. That's all they care about,
Right.
To be honest. But it's really this rich, whole Healthspan question here is, how do we maximize that?
We're almost up on 1.5 hours, and I don't know if there's any burning questions in the audience, but I would love to have maybe to ask Susie to wrap things up for us too, because as I said, between Susie and Julia, there's about, 100 years or so of experience here in cancer advocacy.
I'm feeling really old now.
Yeah, right, exactly. Most of us would say that's a good thing. We want to be really old, not just feel it. So
What you really want to be is I think my aspiration is to die young at an old age. And that may be just young at spirit, because I know the body is not going to be fully willing.
Yeah, I think we've learned that lesson big time. Susie, do you want to wrap things up first? I do want to say my own personal thank you to Julia, because this has been really wonderful and much, much needed for our group. We need to do this more often. So I'll let Susie end up.
I don't have much to add to all of this. It's just been an absolutely wonderful discussion. And Julie, you just really hit the nail on the head, but also you raised a lot of issues that I think can be explored in the future. With what everybody is talking about in the chat room here, I think we could have we have lots of ammunition for getting more speakers to come in and help us with this. But thank you so much for your time. And Erin, I think you're really, really on the right track. You know, just to trying to help this particular group of survivors who have never been compartmentalized before, to really look at the issues of long-term survival and how we get through it. I mean, I say to people all the time, I am thankful to be here. I'm thankful to be getting older. I just wish that my body felt as good as my spirit does at times, and that's accelerating. I know it's accelerating. But anyway, thank you so much, Julia, for your input, and we'll probably be asking you to come see us again.
Absolutely.
Well,
Absolutely.
it would be a privilege. One of my, just a parting reflection too, I've long thought that for all of our oncology professionals, when they're trained, they should have to do like a 6-month rotation to a survivorship clinic. The trouble is a lot of centers don't have a survivorship.
Right.
But so that they understand this is the consequence of treatment, that you need to know that people have lives after you've seen them. And you want to make sure that you are thinking about what that looks like and could be when you are in the front end. I just think it would change practice in here, the other side of the experience. Anyway.
I think we would agree. Thank you so much.
Thank you for the opportunity.
We'll do it again. Thanks to everyone for being here and taking the time out of your day. And with any luck, we've managed to record the whole thing, or at least most of it. So despite the fact that we're often technically challenged here, and I'll take the brunt of that problem, but we'll see you soon. And thanks again to all.